delivering and evaluating HIV-infected individuals for cardiovascular disorders. Thank you.
Respected chairpersons, and I would like to thank Dr. Gilada and the organizing committee of ASICON to give me this opportunity. In fact, Dr. Ashutosh Biswas has simplified my presentation, and some of the answers probably I'll answer in my presentation, some of the questions which were asked. So HIV has become a chronic disease, and now very few patients are actually dying of true AIDS-related problems, and now other problems, which are non-AIDS-related, which are related to aging and other things are emerging. I think Dr. Ashutosh already talked about it. And there's increased prevalence of non-AIDS-related comorbidities, and cardiovascular morbidity is one of the most important morbidity. I'll give you a case summary. This is a patient, Rajkumar, 36 years old male. He had HIV and pulmonary cox, which was detected in 2006. And he was started on ATT for 6 months. He was on stavudine and lamivudine and nevirapine from an ART center, government ART center. And he came to our emergency at Apollo Hospital with acute antiviral MI with cardiogenic shock, 3 years after starting the treatment. At the time of admission, his weight was 78 kilograms. Blood sugar was 309, HbA1c 9.4. Total cholesterol was very high, 532. LDL cholesterol was 208, triglycerides 250, so all the lipids were high. HDL cholesterol was very low. CD4 count was very good, 310. Viral load was suppressed, fully suppressed. So we did a coronary angiography. We tried a primary angioplasty, but patient was very, very unstable, and ultimately the patient succumbed. Now, when we went into the records, his baseline CD4 count was just 108. Weight was 40 kilograms. So he gained about 38 kilograms of weight in the last 3 years. He was normotensive at the time of detection of HIV. He was a non-diabetic at baseline, but then we had no records of follow-up for his diabetes or cholesterol and all that. The question is that could he be saved? Of course, I'm talking a couple of years back. So today when we talk about HIV, I think we have to link it with heart disease, and Dr. Ashutosh has already told us that the heart disease is very high in HIV patients. So this study shows that almost all the studies, so this is a meta-analysis, so there's a more than 1.5 to 2%, 2 times higher incidence of CVD in HIV patients. All these studies from 2002 to 2011, even now we see increased risk of cardiovascular disease in HIV patients. Already these risk factors have been discussed. So, there are the traditional risk factors of age, sex, family history, inactivity, abdominal obesity, cigarette smoking, hypertension, hyperglycemia, etc. But there are new risk factors which are related to HIV infection and related to heart. And we have seen that the use of PI, a lot of studies have shown there is an increased risk of MIs in, when PI-based regimens are used. Also, there's a controversy regarding using abacavir. Quite a few studies show that there's increased risk of cardiac disease or cardiovascular morbidity and mortality with recent use of abacavir. If patient has been on long-term abacavir, probably doesn't increase the risk. But there's a little bias in the study because some of these patients probably have a kidney disease. Abacavir is a nephrosafe disease, and because of the kidney-related problems, there could be an increased mortality. So some studies shows increased risk, some studies show that there's not much increase in the risk. Then of course, non-PIs, we have been using stavudine and zidovudine. Now of course, they are being phased out because of their multiple toxicities. So they also increase the triglycerides. Efavirenz, nevirapine, to some extent increase triglycerides. Nevirapine is a better drug. The new drugs like raltegravir, dolutegravir, etc. are much, much better. Maraviroc are much better in these terms. So this baseline knowledge is very important when we select a therapy. So whenever a patient comes to us, we should try to assess the individual risk factors as part of the initial medical visit. So fasting plasma lipid levels, presence of diabetes by using HbA1c or fasting blood glucose, smoking habits, diet, exercise, family history of CAD, hypertension, diabetes, baseline blood pressure, waist circumference, body mass index. So these are very, very important, assessment. Then there are new, biomarkers which could detect early atherosclerosis in HIV patients: carotid edema, media thickness, arterial stiffness, flow meter deviation, coronary endothelial function and flow, which can be studied by PET scanning, coronary artery calcium scoring. So all these will also add up to our CV risk scores. So whenever any patient comes to us, very important to take history of, personal history or family history of cardiovascular disease. hypertension, diabetes, personal habits, smoking, exercise, family history at baseline, and then update whenever the patient comes to us, because patient may start smoking, over a period of time. He may not be a smoker to start with, he may become a smoker later on. Then physical, weight, BMI, waist circumference, blood pressure at baseline before starting ART, and then we should check it, periodically. Then fasting lipids, fasting glucose, creatinine. Of course, renal function assessment at baseline is very, very important. And we also do it at 3 to 6 months and after starting ART, and then annually. Then, of course, we do calculations, risk score calculations, and we have got various scoring systems like Birmingham's scoring system, which was actually started in the late 90s, validated in 2008. And basically, it is based on the risk factors, but it was developed for the use of general population. It doesn't include HIV-specific factors like immune status, increased inflammatory marker, and insulin resistance. So, there are other scoring systems also which have come, ATP3, ACCHA, ASCVD, and a lot of studies have been done, and ASCVD has shown to have a significantly better, I would say, predictive value compared to Birmingham scores. And there's a DAD scoring system which has come for HIV specific, but that also has not shown much of a difference between ASCVD. Now, always there's a problem. Whenever we predict, we find that actual rates are much higher. So many times we see that these scoring systems underestimate the risk. There's a study in Indian patients in general population, non-HIV, and they found that in our Indian population, because there's a high incidence of metabolic syndrome, the scoring system underestimates the risk. Now, there's one study which shows that as far as cardiovascular events are concerned, Birmingham is a good thing, and another scoring system is not so good. Whereas for ischemic heart disease, Birmingham overestimates the risk, whereas other scoring systems don't. So this DAD study was done, and they incorporated, HIV-specific markers, and they found that this was actually a better thing, but they did only for 5 years. Normally, we assess a 10 years risk. So extrapolation was done, so it's still not validated. So when using FHS-CVD and FHS-CHD, a higher overall CVD risk was attributed to HIV-infected patients than when using a DAD, ASVCD, or SCORE Netherlands model. So right now, ASCVD and SCORE Netherlands models are still better. So do we need something better? I think we need something better. And there's an unmet need for a proper risk stratification on scoring system for HIV patients. And all of us should work on this. I think all of us should get together. We should collect data, and we should try to find an ideal scoring system which can accurately predict the risk of heart disease, because intervention is important. If the patient is a low risk, then we don't have to intervene, unnecessarily put him to statins and other drugs which can have drug interactions and can be toxic. But if the patient is high risk, then we should start, drugs like statins and aspirin, and probably, be more aggressive in their treatment. Drug interaction is an issue, which of course we have to evaluate the risk-benefit analysis and see which is better. So to minimize the risk of CVD, we should advise for exercise and diet modification. Smoking is a big issue. Recognizing and managing dyslipidemia is also another big issue. Diabetes mellitus, hypertension control, and use of aspirin in certain population. Usually we use it as a secondary prevention if patients have already had a cardiovascular event. But sometimes, if the patient is at very high risk, we may resort to using aspirin as a primary preventive measure also. Most of the patients, which have been studied, the incidence of smoking is pretty high in HIV cohort compared to non-HIV. In fact, in one study, they found that 58% of patients, they had, incidence of smoking, vis-a-vis 28% in non-HIV cohort. So it's always better to ask about patient smoking, advise about the health risk, assess the willingness to make a quit attempt, assessed by giving counseling, using drugs like varenicline or nicotine patches, and of course, we should follow up these patients. Now, regarding dyslipidemia, which is also very, very important in preventing heart disease managing. Now, there are two strategies which have been studied. One is a switch strategy from less friendly drugs to more lipid-friendly drugs, and the other is using statins and other lipid-lowering therapy. Rosuvastatin and atorvastatin have been found to be very useful in such patients. But there are other drugs like glitazars, which have been used in diabetic patients to reduce triglycerides and HDL, then fibrates, azithromycin, and fish oil. So these are also adjuncts to lipid-lowering statins to lower the lipids. But the problem is the drug interactions, because most of these drugs interact with drugs which are metabolized through liver, especially protease inhibitors. And simvastatin, which have been used in the past a lot, in fact, most of the studies have been in the simvastatin, now it is contraindicated. And we are using friendlier statins like atorvastatin and rosuvastatin. Now, lipid management, in spite of using statins, may be suboptimal in HIV patients, and probably this is because of drug interactions. Dyslipidemia is more difficult to treat in HIV patients compared to non-HIV cohorts. So one has to be more aggressive, but the limiting factor is if you raise the dose, the toxicity may increase because of drug interactions. So it's a big limitation. We cannot go at a very high dose. Sometimes, we go up to 80 milligrams of atorvastatin in non-HIV patients. But if we escalate the dose in HIV patients, there can be a drug interaction and a problem. Now, if you're not able to reach the cutoff, then sometimes we have to modify the ART, change the drugs. But the only thing is that we should not compromise the HIV suppression, because if we change the therapy and the viral load is not suppressed, then we lose the patient. A lot of studies have been done to show that, abacavir and tenofovir are more lipid friendly compared to the earlier traditionally used zidovudine and stavudine. And lopinavir, ritonavir was more I would say, lipogenic compared to drugs like atazanavir and darunavir. A lot of studies. So overall, atazanavir and darunavir boosted have favorable lipid effects and tolerability compared to other PIs. Efavirenz compared to raltegravir, efavirenz was more lipogenic compared to efavirenz, which is more lipid, compared to raltegravir, which is more lipid friendly. So probably in patients who are at a very high risk and we are not able to control, we can use integrase inhibitors as a first choice of drugs. So sometimes selection of therapy, may be important. So lipid lowering agents definitely are better, but switching antiretroviral therapy also helps to reduce the lipids in such patients. So, if we assess the patient and the patient has got a low to moderate risk, first we try lifestyle intervention for about 3 months, and then we start pharmaceutical management. So we can start with lipid lowering therapy depending if the LDL cholesterol is more than 100. We can increase the dose, up to maximum level, or we can alter the therapy and we can put the patient or switch a patient to a more lipid friendly therapy. So both these combined approach can actually reduce the cholesterol and reduce the cholesterol. In high risk patient, I think we should start pharmacological management along with the lifestyle management. So we should not wait for these 3 months. In high risk patients, we should combine both together and follow the same algorithm. Now, as far as diabetes and hypertension is concerned, the guidelines are the same as in non-HIV patients. We must use GTT or fasting HbA1c, fasting sugar rather than HbA1c to diagnose. But we must check repeatedly fasting sugars, BP sugars, and HbA1c every 6 to 12 months, even if the patient is diabetic. In diabetics, of course, we should do it every 3 months. And lifestyle intervention and following ADA and ACE treatment guidelines is very, very important. As far as hypertension is concerned, we must check blood pressure regularly because incidence of hypertension is high in the HIV cohort, as discussed by Dr. Ashutosh. And we must follow the existing JNC guidelines for general population. There are no specific guidelines for HIV patients. And we must also understand that some of the drugs have drug interactions, so keep that in mind whenever you're using a therapy for hypertension. Now, reducing CVD risk factors can really decrease the risk of CVD in older HIV patients. Smoking cessation, reducing cholesterol, and systolic blood pressure has really brought down the cardiovascular risk. So, to summarize, most important thing is smoking cessation, lifestyle modification, managing dyslipidemia, treating disordered glucose metabolism, appropriate ART strategy, and managing hypertension. So this will reduce the CV risks in most of our patients, and I think we'll be able to salvage a lot of patients who ultimately succumb to non-HIV-related cardiovascular events. Thank you very much. I mean, the gender difference is the same as in non-HIV cohort. It is the same. There's no difference in HIV cohort vis-a-vis gender difference. Because previously actually we thought that, the female gender had less cardiovascular disease. But now, it is coming up that in postmenopausal group, they are catching up with the male gender. And there's no specific studies in HIV as far as, gender discrimination, as far as risk is concerned. But definitely at an earlier age, it's more in the male, but at a later age, when the patient comes to us, say 45 or 50 plus, the gender difference actually, in fact, now is going in the other direction.
So you mentioned that we should consider switching ARVs which are more lipogenic in certain patients.
Which are less lipogenic.
Switching to less lipogenic.
Yeah.
As you yourself mentioned, it's always a challenge to switch ARVs in well-suppressed patients. So how liberal would you be in switching to?
Yeah, that's, you see.
Will you set any cutoffs in
the most important thing is that we must switch, must make sure that the viral suppression is maintained.
Absolutely.
So that is of utmost important. So, if there's a risk that there may be a viral rebound, then we would rather not switch.
Sir.
If we can ensure viral suppression, only then we switch.
Yeah, in
So
that
we cannot say, for example, a patient is on a PI boosted regime along with, say, another drug, and we think that, okay, we switch to a drug like reltegravir, which may not be a very effective drug in the absence of a proper backbone therapy. I would rather refrain from that. I would rather switch to a more lipid-friendly protease inhibitor in such a case, unless I'm very sure that the other backbone therapy is robust and it is suppressing the viral load.
So my question is, at what level of cardiovascular risk would you consider switching? Switching is always a problem. Even in a well-suppressed patient, I would think twice before switching.
Definitely, definitely. See,
So
that's why I said that.
Would you suggest an LDL cutoff or a cholesterol cutoff or a statin dose beyond which we should not go?
I think all these factors we have to take into account. We have to see the LDL cutoffs if we are not able to reach the target, depending on the patient's risk. Suppose the patient already has had an MI. We would like to bring down the LDL to less than 70. And we try to increase the dose of one of the statins to a level, maybe about, say, we can reach a rosuvastatin level to 40, we should not go beyond 40 because there is a risk of drug interactions. In spite of that, we are not able to attain that, and there's a very high risk, then we think of lipid-lowering therapy.
Basically,
so we have to, that's why we have to do a risk stratification. Depending on if the patient is hypertensive or diabetic, then the LDL cutoff is 100. If he has a coronary artery disease, even we go even below 50 in very, very high risk patients. So if we are not able to bring down the LDL cholesterol to below 50, patient is a very high risk, then we have to consider switching.
So we use conventional risk factors.
Absolutely, absolutely. That's why in HIV cohort, there's an unmet need, to develop a scoring system. That's why I want all of us who are, participating in this conference to take up this project and do risk factor assessment and come with a proper scoring system so that, we can really stratify, okay, this is the guy who needs aggressive therapy, this is the guy in whom we can be liberal. So I think this is what is required. This is the need of the hour. So I request all of you to participate in this study and maybe come with our own publications. And Indians have their own ethnic, problems.
Okay, if no more questions, thank you.